Yeah, thanks, Chris, for all his hard work on this. Super interesting. I mean, my personal take on it is that clearly 13 patients over 4 years, there's definitely patients that will benefit from that we're not. I certainly don't think we're going to be dropping this in road jobs all around the place, but I think for patients with isolated chest trauma and a helicopter transfer, I think it's a reasonable option. Because we know about the morbidity and mortality associated with these injuries. We know from in hospitals it reduces opiate consumption. And what else have I written? So improves pain scores as well. I think that's important. You know, moving a patient is a sore thing to have done. I mean, personally, if I had an option of a parenteral opiate versus a block as first up, I'd probably just take a block first up, please, and not have any systemic side effects. But there certainly are patients out there that are suitable for a block that we are not performing a block on. But I don't think we're going to advocate for this. I mean, like, sure, it looks great. You can see the city in the background, but I don't think we should be really performing these blocks in a moving vehicle. And when Chris publishes this, I mean, that is the best piece of research that's out there. There's this paper that looked at this, published the experience of this one block, and RFDS published a paper looking at 2 erector spinae blocks that they performed. So it's really, really small numbers. But we do know a fair bit, like I said, from our in-hospital practice, and we know that moving patients is sore, and hopefully Chris's paper, when data analysis is complete, is going to give us some really good information about how efficacious these blocks are in terms of reduction in pain scores, and also for which anatomical location of rib fractures they are efficacious for. And then we can not worry about, should we be doing erector spinae, should we be doing a serratus? We can just concentrate on a single technique, and a technique that's really practical for us, because we've cast all those other blocks aside for the meantime. We're just going to focus on teaching serratus, because we've got to choose something that is suitable to our environment. So patients that aren't trapped are presented to us normally supine on a stretcher, and this is a supine technique. So we can perform it on the patients that we see in the position they're at. We carry all the stuff to do it. The hospital experience would suggest that it is a safe procedure. We have the patients to do it. And I think even for those that haven't done it, this is a very transferable skill. For those that are familiar with ultrasound, that can perform in-plane needling and fib blocks, it's just like the fib of the chest. It's exactly the same technique. So we will just quickly go over the specifics of the block itself, and then we'll go and do some workshops to Savo. So this is what we're trying to achieve. Anesthesia of the lateral branch of the intercostal nerves, the long thoracic nerve, and the nerve to latissimus dorsi. So these ones here, and we're going to do that by instilling 40 mils of volume, and that's the important thing, 40 mils of volume of dilute anesthetic. And we think that that is going to block anterolateral chest wall of T2 to T9. But there's some cadaveric studies where they've broken the ribs of the cadavers and they have injected dye in the usual location. And actually, the disruption of the tissues and fascial plane from the rib fractures results in greater spread. So in traumatically injured patients with rib fractures, you might find you get better spread than that. And that's why anecdotally we have colleagues that are performing these for posterior rib fractures and still finding that they're efficacious. And hopefully Chris's CT mapping of his injuries on his studies is going to help. So as I said, supine with the arm adducted. And we're going to do 2 workstations this afternoon. We're going to do some needling, but we're going to do some sonoanatomy. And we're going to try and identify the normal anatomy. So it's supine patient with arm adducted. And you can see here the probe pointing towards the ceiling with the needle coming in plane with the aim that you're going to deposit local anesthetic at the T4, T5 level around about the mid-axillary line. I don't have my pointer. So if we look at the screen here, oh, yeah. Awesome. So this with the probe markers pointing towards the ceiling, pointing towards the bed. So this triangle here is latissimus dorsi, so tapering to a point. Beneath it is serratus. So serratus is sort of striated, but it's hypoechoic, so it's less bright than latissimus. Have a rib here. Slide up. You see normal rib shadowing, and then pleural line with pleural sliding. Everyone happy with that anatomy? No questions? That's it labelled up. So serratus sits deep to latissimus, and it sits above intercostals. Looks hypoechoic. And as you slide up, you're going to see latissimus disappear. And this is what we're going to try and do in terms of depositing local anaesthetic. So the that is a high volume block, isn't it? So the anaesthetic has got to go in one fascial plane. You can't sort of put half above and half below. You can put this block in two locations. You can put it superficial to serratus, you can put it deep to serratus. Very limited evidence, but it might be slightly more long-acting if it goes above. Maybe it has a slightly better safety profile if it goes above, because you don't have to put the needle as close to the pleural. Going deep, you have the advantage that you can put the needle onto the rib and feel that. That tactile endpoint is a really useful thing, particularly if there's lots of subcut emphysema that impacts your direct visualization. But I think the take home is probably deep is easier if they've got subcut emphysema, but both are feasible, and I would go for whichever looked anatomically easier. I think this is a super good example of in-plane needling. So you can see the whole needle, can't you? And then you can see the bevel at the end, it looks brighter. So they visualize the needle, the whole part, and they haven't inserted it further without visualizing. Typically, you can see a little pocket of local anaesthetic with latissimus tapering here, serratus here with the rib shadows here. So this one here is going deep to serratus on the right, and this one here going superficial to serratus. So Ab's had his shirt off before, your lats are massive, yeah? Yeah, that's... that should be good. So that's what we're going to do. In one half, we're going to try and identify all that sonoanatomy. The other half, we're going to try and focus on some really precise in-plane needling. And one of the reasons we've sort of swayed away from teaching this previously is it's fine to just find someone to ultrasound and identify the anatomy. But actually trying to do sort of fascial plane injections, well, we don't really have a way to do that. So I've had my R&D team on it. One loves playing with scissors, one loves making more meat. So they have done a good job, and we have created some Mark 1 serratus phantoms. You need to try and do so. They're not perfect, because obviously one's a cat and one's only 5. But they're not bad. Certainly, they have the appearance of latissimus and some fascial planes. You can actually do some injections on them, and you can go to town on them because